So now we're going to examine a handful of drugs that are used to treat hyperthyroidism. So the first one is methimazole. Mechanistically, it's going to block that enzyme, thyroid peroxidase, which essentially halts the organification of iodine. And again, clinically, we're looking at treating hyperthyroidism. This drug is orally administered. It's got a long duration of action, about a day. And adverse effects include nausea, GI discomfort, rash, agranulocytosis, and then, of course, an overdose, hypothyroidism. And typically, we're looking at treating these various hyperthyroid conditions. We're lumping them all together, but of course, if there's a tumor that's causing hyperthyroid type phenotype, where the first thing would be to get the tumor out and then treat accordingly. Another kind of along to that degree, we're looking at propylthiouracil or PTU. Again, clinically indicated for hyperthyroidism. It'll block the organification of iodine by halting that enzyme thyroid peroxidase. And really this kind of stops the peripheral deiodination of T4 and T3. It's got a shorter duration of action, about 6 to 8 hours, and with similar types of side effects or adverse effects. It is associated with hepatitis, so it comes with a black box warning, of course. And typically, patients aren't given propylthiouracil for very long periods of time. This is just to really kind of get a hold on these really high T4 and T3 levels, just so that the patient's normal homeostasis can kind of return to baseline. And typically surgery is also part of the treatment. Oops. And so just to kind of recap, here's your thyroid gland. Here's how the iodines get organified and basically get incorporated into the chemical structure. You see a release of T4 and T3. Of course, T4 in the periphery gets converted into the more biologically active T3. And then there are other drugs that can inhibit this conversion. And so iodinated contrast media, beta blockers, amiodarone, the antiarrhythmic thiamines, all can inhibit or slow the conversion of T4 to T3. Okay, so iodines, the more commonly referenced one is the Lugol solution. And this is a kind of a saturated solution of potassium iodide. And here we're going to see inhibition of organification of these hormones. And it's also going to reduce kind of the size and the vascularity of the thyroid gland, which is really iodine dependent. What are we indicating this for? Essentially, we're getting the patient prepped for surgical thyroidectomy. It's got a really fast duration of action, less than a week, and of course this is orally administered. Beta blockers, we haven't talked about those in a while. There are beta receptors that are associated with the conversion of T4 to T3. Remember, propranolol also has some intrinsic sympathomimetic activity or partial agonist type of activity on some beta receptors. Indicated for hyperthyroidism, thyroid storm, the adjuvant treatment for the control of tachycardia that sometimes accompanies thyroid storm, of hypertension, of course, and atrial fibrillation. In terms of the emergency room type of treatment protocols, we're looking at specifically esmolol, another beta blocker, to really be a good agent for the thyroid storm problem. We can see both oral and IV administration. The onset's really quick, it's within the hour, and the duration of activity of orally administered drugs lasts anywhere from maybe 4 to 6 hours. And of course, you're familiar with some of the adverse effects of beta blockers. Radioactive iodine, or iodine-125, this is going to cause radioactive destruction of the thyroid gland, clinically indicated for hyperthyroidism. And so, of course, we're going to have the patient also on a beta blocker before the radiation therapy to kind of alleviate some of the symptoms of this thyroid storm. Patients will start taking the radioactive iodine orally that onset of activity can be anywhere from 6 to 12 weeks. And some of the patients will complain of sore throats. Hypothyroidism, of course, is going to be an outcome. And so what do we do? So all these patients that are hyperthyroid essentially get the thyroid gland either removed or surgically removed surgically or chemically annihilated with something like radioactive iodine. What happens to them then? Well, then they become hypothyroidic, and we treat them with Synthroid. So at the end of the day, all the patients will be put on Synthroid. The patients that are hyperthyroid will have to have some of these, I would call them anti-thyroid type medications, given to them for at least a short period of time. The offending thyroid tumor will be removed, and then the patient's T4 levels will normalize more or less, and then become low. And then at that point, they would start on Synthroid or one of the other thyroid therapies that we had talked about for hypothyroidism. So that's relatively a simple concept here. These are some nice kind of guides that I grabbed from the literature, the citations listed there. This is table 8 here, clinical situations that favor a specific modality as a treatment for a toxic multinoder goiter or toxic adenoma. And so these are the different things that you can do surgically or with drugs to essentially treat these patients. And then of course in terms of treating the thyroid storm specifically, there's a little bit more literature on that. We don't need to go into great detail for the sake of step 1, but just clinically understand that there are drugs that are used for various different clinical indications that go along with the thyroid storm, which we've briefly summarized. So that's pretty much it for thyroid therapy. So we'll end here, and we'll pick up on another topic.